Um, Click over the next one. It's important we understand a little bit about this because it's becoming a more important phenomenon that we have seen in the last few years. And Aspergillus is in the air. It's in environmental mold, particularly when there's building work going on, and we're inhaling it all the time. It doesn't cause us a problem. But in patients who are sick, and there are risk factors for Aspergillus, it can cause a problem. These here are the traditional risk factors, but in recent years there are these other risk factors which are becoming more significant, particularly on the bottom line, these viral respiratory illnesses, COVID, influenza, and RSV. And awareness was raised about this particular problem in 2018, and there was a paper that came out then saying that there's a very high incidence of Aspergillus after flu. And in the typical year, PV, ECMO, we're often doing it for flu, and we're wondering why people are not getting better, and some of them may actually have this phenomenon going on within their lungs. But it's quite a complex problem. When you try and get your head around this, in terms of the testing, and what you find, and when to treat it, and what to treat it with, it's actually quite complex. The other thing that's worth remembering is if you take a large population of patients who have pneumococcus, about 5% of them will then get Aspergillus in the lung. And in this study here, there's about 400 cases of ARDS, and it was estimated about 8% of them, 1 in 12, got Aspergillus. So it may not be totally related to flu and COVID. It may just be a function of patients who are on ventilators for a prolonged period of time and being exposed to what is an environmental airborne disease. So the questions I'm going to try and go through this afternoon are these. What's the true incidence of it? Do corticosteroids increase the risk of it? What's the best way to diagnose it? And some of these other things. You can read it on the slide there. It's worth thinking about the two diseases that we spend a lot of our time looking after, severe flu and COVID, and they're slightly different. If you think of COVID, we often give steroids early. Sometimes we're giving an IL-6 blocker, and it's said that patients develop kappa around about this COVID-associated pulmonary Aspergillus, but not many of them go on to develop angioinvasion, which is much more serious, it's harder to treat, more serious. With flu, we give some oseltamivir. At the moment, we don't give steroids early. If anything, they're given later. But instead, angioinvasion occurs in more often. Let's go back to the original study which raised this as a potential problem. This is the study, 400 cases of influenza, and around about a fifth of them, we were told, had pulmonary aspergillosis. But what was interesting and highlighted by these two things I've put here, is the sort of the traditional risk factors which are used in hematology and oncology were present in only a minority of them. And so I think people weren't thinking of Aspergillus as a potential problem. And the other thing that was highlighted here is that giving steroids seemed to be associated with an increased risk. Now, when it comes to COVID, the situation is really very complex indeed. When you want to work out what the incidence of it is, this tracks. I put the studies here in order of publication. pandemic started in March 2020, and this is the incidence, and these are the countries it's from. You'll notice there's nothing from Vietnam. So I don't know if you don't get Aspergillus or you just haven't published your data, I'm not sure. But there's an opportunity there for somebody here to go back into your records and to work out how many patients you thought had Aspergillus and publish it, because it's quite interesting. But you'll note the variation. Look at this. In England, 0%. Germany, France, very high rates. This is a different way of expressing the same data. And what is confusing about this whole area, if you look at it, is each colour represents different criteria to diagnose it. The size of the circle represents the size of the study, and you can see the incidence here along the y-axis, and the publication here, whether it's prospective, retrospective. So it's very difficult to know what's going on. It's really quite a confusing picture. I like this study because I think this one is the best because it gives a better picture of what's going on. It's a French study. And I think first of all, look up here. This is very similar to what we saw. Aspergillus rate of about 15%, very little mucor, high rates of bacterial VAP, CMV reactivation, HSV reactivation. So you can see when you've got a patient who's got COVID and they're not getting better week 2, week 3, there's a whole host of secondary issues that could be a problem. Bacterial infection, CMV, HSV, all of these need to be looked at and potentially treated if you diagnose them correctly and then give the right therapy. But what also came out in this study is that 3 factors seem to predominate for the risk, particularly for Aspergillus. Older patients, not steroids, but it's the combination of steroids plus IL-6 blockers, and then prolonged exposure, long duration of mechanical ventilation. We'll skip over this slide because I don't think this adds very much. This is an interesting study because this is an autopsy study where they've actually looked at patients who died from COVID and said, can we find Aspergillus in the lungs? And in this study here, very few patients could they find Aspergillus in the lungs. And so the author said, well, maybe the clinicians are just overdiagnosing it, and they're finding Aspergillus in a respiratory specimen, and then thinking that it's invading the lungs and causing a problem, but maybe it's not. I would caution that as being the right interpretation, because I think this study has what we call selection bias, and often the patients who go for autopsy is where you don't know what the diagnosis is, and they've died very early in their course, and maybe it's not representative of the population as a whole. In our hospital, early in the pandemic, we did a number of post-mortems, and we did find Aspergillus in the lungs. And in our population, it was around about 6% overall. We think with reasonable way of diagnosing it. So let's ask first of all, why such a variety, a variation in rates of incidence? It's possible that there really is regional differences in the rates. But as I said, there's data lacking from a number of regions that would be nice to know. I'll show a slide of this in a moment, but there's enormous difference in terms of the way in which you're diagnosing it, what tests you use, what criteria, and everything else. There's a difference in prospective and retrospective studies. It's very difficult to absolutely prove that the patients have this diagnosis because it's hard to get histology or do biopsies of the lungs while the patient is alive. And so most of the time, we're dealing with uncertainty, and we're saying the patient either possibly has it or probably has it. We can't prove it for certain. In order to get it, you actually have to keep people alive for quite a long time. And patients don't normally have it within the first week. It seems to be later on that people are picking it up. And something that is also quite interesting, if you think about it, normally when somebody is neutropenic, we put them in a positive pressure room so that they're breathing in clean air. But what we did with COVID is we immunosuppressed them with steroids and IL-6 blocker, and then we put them in a negative pressure room to keep us safe. And actually, potentially, it sucks in Aspergillus from the outside, and that might be why they're more at risk of getting it. That's a hypothesis anyway. If you're interested in this particular area, I think this is the one paper you need to read, because I think it gives a really good overview of what to do, and it gives some very good criteria for research and for clinical guidance. And what this particular paper does is it gave criteria that could be used for proven, possible, probable type of infection. And it was quite practical because it said, you clinicians who are looking after very sick patients who are getting immunosuppressant drugs, who've got prolonged ventilation, it's hard to get the right diagnostics. When you find some Aspergillus, they're so sick, these patients, you don't want to leave them untreated, and yet you don't want to over-treat them. So it gave some very good guidance as to who to treat, when, how long, when to stop the therapy, and whatever. I can't go into the detail for the sake of time, but I think if you are interested, download this particular paper, and you'll find that very helpful. It gives a lot of advice also about how to manage it, what drugs to use, and the downside, upsides of all of the different interventions. This slide shows the problems with the different definitions. Each of these represents different definitions used by the various different authors. And you can see there's no sort of consistency at all. And that also accounts for a lot of the variation that occurs across the world, because people were using different definitions, and hence that might contribute to why the incidence varies in different places. This is also another interesting paper, but it points out some of the problems with some of the tests which are currently used, and the problems that we face in the patients that we look after. Pointing out that the range is anywhere from 0 to 33%. Accepting the fact that biopsy is almost impossible in our patients, we just can't do that. In hem-oncology patients, they often look at serum galactomannan, but in the overwhelming majority of the patients in ICU, that's negative. Just because it's negative doesn't necessarily mean that they haven't got it. Beta-D-glucan is not specific for Aspergillus. That could be positive with PJP, or it could be positive with Candida, so that doesn't necessarily help us. And there's not a lot of data in NBL or tracheal aspirate. Most of the data is with a bronchoscopic lavage. And certainly early on in the pandemic, people weren't prepared to do that because of the risk of aerosolization. And so it's possible that people were overdiagnosing it. I think when you're on ECMO nowadays, it's much easier to do that. and with all the precautions that we have, I think it can be done. CT scanning is used very frequently in hem-oncology patients, and you see the typical signs on the lungs, but with COVID it's just not possible. Yes, okay, it might help you rule out other types of lung pathology, but it doesn't necessarily help in making the diagnosis. The good thing is that there are some newer tests coming along which may help us in the future. This may seem a very strange question to ask. Does treatment actually make a difference to the outcome and improve the outcome? And the reason why you say that is almost all of the studies show that the patients who get pulmonary aspergillosis have a higher mortality. So why would treating them surely must make a difference to their outcome? But the interesting thing is some of these patients with possible or probable pulmonary aspergillosis seem to get better without any treatment. The other thing is that very few of the studies have actually looked at whether therapy has an effect on outcome. It seems to reduce galactomannan levels, but actually in the data we have available, it's very difficult to prove that treating it actually changes their outcome. We'll come to why that might be in a minute. Well, it's on this slide here actually. And certainly our experience from particularly using voriconazole is that the levels of voriconazole can be very unreliable, sometimes high, sometimes low, which is why in very sick patients who we think may have it, who are on ECMO, we always use 2 agents at the beginning and then only cut down to 1 agent of voriconazole once we're certain that we've got therapeutic levels. And it's interesting that that's similar to what they do up in Hanoi. I don't know what your practice is down here, but if you really think the patient has pulmonary aspergillosis, 2 agents until you're certain that the patients are improving. We've also used some nebulized amphotericin occasionally and learned that if you do a circuit change on these patients, because the drugs are taken out of the circulation and they bind to the ECMO circuit, you may have to reload the patients. It's a little unclear how long you should give therapy for, but in this particular paper they're suggesting anywhere between 4 to 12 weeks. And because the outcome is so poor, some people have said, well, why don't we just give it prophylactically? You know, if the rate in our population is 30%, why don't we just give it very early so that this improves outcome? Well, at the moment, there aren't any data out there on prophylactic treated patients, but there are some studies which are ongoing, and they may well report fairly soon. So, the proposed guidance is quite practical. It sort of says, think of it as a possibility in anybody who has unexplained deterioration. Certainly when you get to weeks 2, 3, patients deteriorating, think secondary bacterial infection, think reactivation of viruses, CMV, HSV, think, could this be pulmonary aspergillosis? I think it has to be said, if you want to be certain of your diagnosis, you need to do a bronchoscopy so that you know you've got a good specimen from the lungs. And if that specimen comes back as being negative, then you can stop therapy and you can say, well, it's unlikely that they've got it. Also, you may want to image and sample to rule out other infections, but again, if your tests come back as negative, then you can stop. But if you see fungal hyphae, it doesn't necessarily mean that they've got it, but probably you're going to want to continue to treat. But I think in the future, we're going to reach a situation where the definitions are a little bit better, things are clearer as to what's going on, there'll be some better tests that will help us distinguish what's going on. And and take away some of the uncertainty which is currently there. So we'll finish, and then there may be time for a few questions. Is that you need to have a high index of suspicion, and there's a suggestion that the more you look, the more you find. Wide variation in the incidence depending upon the cohort. And as I said, the definitions need refining. Treat it promptly, but do the right diagnostics, and then they all come back as negative. Then you can stop therapy and say it's not present. I'd be interested to know how you approach this here, and whether you've got any feeling or understanding or data in what the incidence has been in the COVID pandemic that we've been through in the last couple of years in Vietnam. Thank you very much. I'm sorry I just went straight through it, but I think okay. And what are you treating it with when you see it?
biomarkers for Aspergillus, like bromocriptine or
if the galactomannan is positive in the serum, then you know you've got it. But if it's negative in the serum, it's not necessarily, you know it's not there. That's the problem. There isn't any marker like procalcitonin that's readily available that gives you a really good clue. So what tends to happen is you'll take a sample from the lungs, and you might see fungal hyphae. PCR might be positive. These don't mean that they've necessarily got invasive infection that needs treating, but you say it's possible, probable, and you have to treat. It's very hard to prove it absolutely. That's one of the problems, because the CT scan looks pretty bad. You can't do a biopsy and prove it like you might do in other situations. So you have to sort of embrace this uncertainty, and in some of them just treat them for several weeks, saying, well, it could be there. I've given them steroids, I've given them an IL-6 blocker, they're not getting better. It's not bacterial infection, it's not viral reactivation, it could be that. And that's one of the problems. We like to be certain, don't we? But you can't always be certain in this situation.
I have another question for the liver failure patient, because most of the cases in my department, when they got liver failure very severe and they got candida infection, and I'm not quite sure in Aspergillus case, we've got this fungi for the liver failure patient. I don't have any experience on this case.
With Aspergillus?
Yes, Aspergillus.
In dengue?
Yeah. Dengue or any other disease, when they got liver failure.
Okay. And so what's your concern? You're not sure what to treat them with?
No, usually the treatment with Aspergillus.
Okay.
But I'm not quite sure in the case of Aspergillus, did you have any cases that when they got liver failure and combined with the infected but with the Aspergillus?
So making me think now. Why would you not want to use something like that? Do you have an inigular fungin available? Because an inigular fungin is used a lot by the liver doctors. It's said to be one of the least toxic drugs on the liver, and that would be active as well. And you could use that, couldn't you?
We didn't use any drug that's toxic to the liver. So
but an inigular fungin, I think you could use that.
It has a better side profile compared to castle fungin.
Yeah. Do you,
Both would eradicate the same
yeah.
species.
Do you have a nidula fungin in this available in Vietnam? Only Casper fungin, not. Okay. I mean, Casper fungin, I think you could probably still use that. I think you can use it at a lower dose. Certainly the hepatologists in London, I know, prefer to use a nidula fungin.
But my question is, when the patient got liver failure, they have the immunocompression. So whether or not they have the infected by fungi like Aspergillus or Candida. Because
yeah, I think there's
yeah.
a much higher incidence of fungal infection in liver disease. I think as high as 30%.
Do you have any data for it? How many percent of the patients with liver failure?
I mean, tomorrow morning there's a reference I'll give
okay.
talk tomorrow morning.
I think
yeah, and it's mainly Candida species. Historical data, 32% have a fungidia in acute liver failure.
so. Dr. Esan is going to be dealing with that tomorrow morning. Okay. Any other questions?
I heard that you talk a lot about Aspergillus infection in after the viral pulmonary infection, but what about other pulmonary infection, other pneumonia, other cause of pneumonia? If the patient have prolonged intubation, what is the prevalence of Aspergillus infection in those patients? For example, I work in HIV department, and some patients have PCP, pneumocystis pneumonia, and they respond. Sometimes they respond very slowly with the treatment. Even if we treat PCP and tuberculosis, both of them, and they respond really poor, and sometimes the bacteria evidence of pneumonia is not present. So how do you think about that?
So there's two studies that I could quote you. One is that if you take patients with pneumococcal pneumonia, it's said to be 1 in 20 get pulmonary aspergillosis. If you take all comers with ARDS, it's 1 in 12 of them. And I agree with what you said. I think PJP is slow to respond. Pulmonary aspergillus, you have to be patient. You know also with things like the viral reactivations, HSV, CMV, they don't get better quickly, they get better slowly. It's not like treating bacterial infection. So I think it's like a lot of these things, the more we do of looking after patients with severe respiratory failure for prolonged periods of time, sometimes the reason why they're not getting better is they've got a secondary phenomenon that we haven't yet worked out what it is, and we don't always treat it with the right therapy. So I think this is a sort of a new thing that, as Guy mentioned this morning, some years ago we only started thinking about viral reactivation, and I think now going forward for a lot of these patients, weeks 2, weeks 3, we need to think, well, is there something else that's going on, and do the right tests to look for it, and then make sure we've got the right therapies at the right doses that actually get them better.
Okay.